Hey there, curious minds. Welcome to the deep dive. We take complex topics, cut through the noise, and get straight to those aha moments. Today, it's an essential journey, especially for you first-year medical students out there. Think of us as your guides navigating the intricate wiring system of the lower limb. Okay, so let's unpack this a bit. Our mission today, a deep dive into nerve injuries of the lower limb.
Yeah,
We'll look at everything from, the basic anatomy, how they get injured, the symptoms, and really why all this matters for actually taking care of patients.
exactly. We want to help you build a really clear mental map of these pathways. It's fascinating how just a small disruption can have such huge impacts. Movement, sensation, the quality of life. We'll use metaphors, some key anatomical anchors, and some thinking prompts, too. The idea is to help you not just understand, but really retain and recall this stuff when it counts.
Yeah, so if you've ever wondered why someone walks with a certain limp, or what's really going on with that shooting pain down the leg, well, this deep dive is for you. Let's get started. All right, let's imagine the lower limb, like you said, a complex city. The nerves are its electrical grid. So where do these power lines actually start? How's it all set up initially?
Good analogy, yeah. So our sources tell us this whole network, the lumbosacral plexus, it's basically derived from the roots of the lumbar and the sacral spinal nerves, L1 down to about S4. Think of it like the main power station, deep in the pelvis. And from there, all the major lines branch out to power the entire lower limb.
Okay, main power station. And from there, two really fundamental ways to think about nerve problems, right? Upper motor neuron, UMN, versus lower motor neuron, LMN, lesions. Super important distinction.
Absolutely critical. Uh, think of it like this, maybe. The UMNs are like the CEO or the brain. They send high-level commands from the brain, cerebellum, brainstem, even the spinal cord itself. They decide what needs to happen. The LMNs, on the other hand, they're the factory floor managers. These are the actual nerve cells in the spinal cord's gray matter, the interior horn cells plus the nerve roots leaving the cord and the peripheral nerves going out. They're the ones carrying those commands directly to the muscles, executing the plan.
Right, so a problem with the CEO's directive, that's going to look very different from a problem down on the factory floor, yeah. Okay, first challenge for you, our future clinicians, keep this in mind. Patient comes in, muscle wasting, you can see fasciculations, those little twitches, and their reflexes are low or absent. UMN or LMN lesion, what are you thinking? We'll come back to that. Hold that thought. Okay, so beyond UMN, LMN, our sources point to two more crucial concepts for mapping things out, especially spinal versus peripheral nerves, myotomes and dermatomes.
Yes, these are like your anatomical address codes, really useful in the clinic. A myotome is basically a group of muscles supplied by a single spinal nerve root, responsible for a specific movement, like a hip flexion. That's mainly L1, L2. Knee extension is L3, L4. Testing those movements tests those roots. A dermatome is the flip side. That's an area of skin supplied by a single spinal nerve root, maps out sensation. So numbness around the inner ankle, the medial malleolus, you think L4 right away. Side of the heel, lateral calcaneus, that points to S1.
Got it. So these address codes are super helpful for pinpointing where the problem is. But before we dive into the individual peripheral nerves, let's talk about a really common issue affecting those spinal nerve roots right near the start. Spinal disc herniation. Right, so imagine those discs between the vertebrae, like sturdy jelly donuts, good shock absorbers, flexible. But what happens when the jelly inside the nucleus pulposus squeezes out?
Yeah, that's a spinal disc herniation. It's a really, really common cause of nerve root compression, especially down in the lumbar spine. What's key to remember generally is that a herniation often affects the nerve root exiting below that disc level. So an L4, L5 disc herniation, it's usually going to squeeze the L5 nerve root.
And that pressure, that irritation that often causes sciatica. We hear that term all the time. It's that classic shooting pain down the leg, right? It's basically an alarm bell saying something's pressing on L4, L5, or maybe S1 nerve roots.
Exactly. And while, a lot of disc herniations can be managed conservatively, there's one condition related to severe compression that is absolutely critical, time sensitive, Cauda Equina Syndrome. CES. This isn't just a red flag, it's a full-on surgical emergency.
Okay, that sounds serious. So next question for our medical students listening in. Picture this. A 34-year-old man, ER, worsening low back pain, weakness in both legs, feels numb over his right foot. And he admits, kind of embarrassed, that he hasn't been able to pee properly for about 12 hours. What diagnosis jumps to your mind immediately, and why is it such an emergency?
That scenario highlights the key question. What are the absolute must-know features of Cauda Equina Syndrome? Our sources are clear. Severe back pain, yes. But crucially, bilateral leg weakness, numbness in a specific pattern. We call it saddle anesthesia. That's numbness around the buttocks, perineum, inner thighs, the S2, S4 dermatomes, and the big one, bladder and bowel dysfunction. So urinary retention, like in a case, or maybe incontinence, fecal incontinence too. It's all because those lower spinal nerves, L2 down to S5, which control the sphincters, are getting compressed.
And that's the answer to the case. Those specific symptoms, bilateral weakness, the saddle anesthesia, the bladder bowel problems, they scream CES. And it's an emergency because delaying treatment, usually surgery, can lead to permanent nerve damage. Permanent paralysis, incontinence, devastating outcomes, often caused by a big posterior disc herniation, but yeah, trauma, tumors too.
Right. And now let's loop back quickly to UMN versus LMN. Cauda Equina is a perfect example of an LMN problem. Remember the first question, muscle wasting, fasciculations, low reflexes. That pattern points strongly to an LMN lesion, like the nerve root compression and CES. UMN lesions, again, typically give you increased muscle tone spasticity, rigidity plus hyperreflexia, and that positive Babinski sign. So in our CES patient, the weakness and bladder issues, that's damage to the factory floor managers, the lower motor neurons, and those compressed nerve roots. Knowing where the problem is in that command chain, that's key.
That clarifies it perfectly. Okay, foundations laid, red flags noted. Let's take a tour now on the main individual peripheral nerves, the specific highways of the lower limb, each with its own route, its own job, and its own weak spots. White up, femoral nerve, L2, L4, powering the anterior thigh.
Okay, first up, the femoral nerve. Comes from the lumbar plexus, specifically L2, L3, L4 roots. It runs down through the psoas major muscle, then crosses over the iliacus, and then dives into the inguinal ligament to get into the front of the thigh. A really important landmark here, an anchor point. It passes right through the femoral triangle.
Yes, the femoral triangle. That's a big one, isn't it? You've got the artery, the vein, and the nerve all bundled there. Great for vascular access, but it means the nerve is kind of exposed, right?
Yeah.
Vulnerable to injury during procedures or trauma there. Damage the femoral nerve. What happens? Big problems with knee extension, maybe can't do it at all. You'd likely see a weak or absent patellar reflex, the knee-jerk reflex, and probably some weakened hip flexion too, plus sensory loss over the front of the thigh and medial lower leg.
Yeah, an interesting point about that sensory loss is terminal sensory branch, the saphenous nerve. It keeps going down through the adductor canal in the thigh. So sometimes you can injure just that branch, maybe during knee surgery, or if someone's harvesting the long saphenous vein nearby for a bypass graft, that would give you isolated numbness on the medial side of the lower leg. A bit more specific. Obturator nerve, L2, L4, the inner thighs controller.
Okay, moving from the front to the inside, the medial side, let's talk obturator nerve. Also from L2, L3, L4 of the lumbar plexus. It comes out the medial side of the psoas muscle, travels across the pelvic wall, and then goes through the obturator canal, another key landmark, its main job. Innervating those medial thigh muscles, the adductors, pulling the leg inwards.
Right. So injure the obturator nerve, and the patient can't adduct their hip properly. This really messes with their stability when standing and walking. Causes significant gait problems. They often compensate with a wide-based gait, kind of spreading their feet apart to feel more stable. Center of gravity shifts. Sensory loss would be, typically over the medial thigh, maybe down to the groin area. And because it runs along that lateral pelvic wall, it's near the ovary in females. So things like ovarian cysts, tumors, or even tricky pelvic surgery can compress or damage it, leading to hip, medial thigh, even knee pain.
Which leads perfectly into our next case study. Think about this. 62-year-old woman just had difficult pelvic surgery, a laparotomy, to remove a big ovarian cyst. Afterwards, she's got numbness, tingling on her inner thigh, and she's walking unsteady with that wide-based gait. Which nerve are we thinking was likely dinged?
Yeah, that's almost textbook for an obturator nerve injury.
Yeah.
Either the surgery itself, the retraction maybe, or even just the pressure from the cyst before surgery.
Yeah.
Could have easily damaged it. Recognizing that specific combination medial thigh sensory change plus the wide base gait points you right there. Money 3, sciatic nerve, L4S3. The lower limb superhighway.
All right, now for the big one. The absolute superhighway of the lower limb. The sciatic nerve. It is the largest nerve in the entire body. Huge. Comes from L4 all the way down to S3, runs deep in the buttock, posterior to the hip joint, usually pops out just below the piriformis muscle.
It's massive. And because it carries fibers from so many roots, its motor supply is vast. It covers the hamstrings and the posterior thigh, and then basically all the muscles in the leg and foot via its branches. So a major sciatic nerve injury. That limb is, well, pretty useless functionally. You'd see impaired hip extension, really weak knee flexion, and basically no ankle movement, plantar flexion, or dorsiflexion, and no toe movement either. This often leads to severe foot deformities or foot collapse over time. Common ways to injure it. Posterior hip dislocation is a big one. Penetrating trauma to the buttock. Or, and this is important, improperly placed intramuscular injections.
Right. That's a critical safety point for everyone listening who'll be giving injections. IM injections in the gluteal region, HVE, to be in the safe zone. That means upper outer quadrant, superior and lateral. Stay away from the path of that sciatic nerve. A common mistake, unfortunately. Many 4. Common peroneal fibula node, L4S2. Driving dorsiflexion. Okay, the sciatic nerve eventually branches. Let's talk about one major branch, the common peroneal nerve, sometimes called the common fibular nerve, same thing. And this one is famous for being vulnerable, right? Because it runs so superficially around the neck of the fibula.
Exactly. That is the key anatomical anchor point for this nerve. The neck of the fibula. Just below the knee on the outside. It's right there under the skin, wrapping around the bone, super exposed. So fibula fractures, direct blows to the side of the knee, even tight plaster casts, or just prolonged pressure, like someone crossing their legs tightly for hours, or positioning during surgery. I even heard about a student getting temporary foot drop from basically studying with their legs crossed too long. It happens. Its job is mainly supplying the muscles in the anterior and lateral compartments of the lower leg.
And when you damage those muscles, you get the classic foot drop. That's the inability to lift the front of the foot to dorsiflex the ankle, which leads to that really characteristic foot flap gait. The foot just slaps down with each step because they can't control it. They also lose ankle eversion, turning the sole of the foot outwards, which makes them really prone to rolling their ankle inwards, getting inversion sprains. Okay, case study number 3 for you. 29-year-old woman, car accident. Got a fracture of the tibial head, the top of the shin bone near the knee with a bit of displacement. She has reduced sensation over the top and side of her foot, kind of L5-S1 area, and she cannot lift her left toes upwards, cannot dorsiflex. Which nerve injury is most likely, and what gait might she develop later on?
Well, given that fracture location near the tibial head, which is right next door to the fibular neck, the most likely culprit is the common peroneal fibular nerve. The inability to dorsiflex the ankle and toes, plus that sensory loss pattern on the dorsum of the foot, it all fits. And if it's not treated or doesn't recover, she will definitely develop foot drop and that slapping gait.
5. Tibial nerve, L4S3, the plantar flexion powerhouse.
All right, the other major branch of the sciatic nerve is the tibial nerve. This one heads down the back of the leg. It's the powerhouse for the posterior compartment muscles, the calf muscles, and also the intrinsic muscles within the foot itself. It's big job, plantar flexion, pushing the foot down, putting your toes. That's right. Crucial for walking, pushing off, standing on tiptoes. You can injure it higher up, like in the popliteal fossa, that space behind the knee. That causes weakness or loss of plantar flexion. Or it can get compressed further down in the tarsal tunnel. That's a narrow space behind the medial malleolus, the inner ankle bone, kind of like the carpal tunnel in the wrist, but in the ankle. Tarsal tunnel syndrome usually gives you sensory changes, tingling, numbness, maybe some intrinsic muscle weakness in the foot itself. And without good plantar flexion or the support from those intrinsic foot muscles, patients can develop pes planus or flat feet, and their toes might splay out when they put weight on the foot. Fix: gluteal nerves, stabilizing the hip.
Okay, nearly there. Let's quickly cover the gluteal nerves, often overlooked but super important for hip stability.
Definitely. First, the superior gluteal nerve comes from L4, L5-S1. It supplies 2 key hip abductor muscles, gluteus medius and minimus, muscles on the side of your hip. If you damage this nerve, maybe from a hip dislocation, a fracture near the hip, or again, a misplaced IM injection, you get the classic Trendelenburg sign. You ask the patient to stand on the affected leg, and their pelvis drops down on the opposite unsupported side, because the abductors can't hold it level. This leads to a compensatory Trendelenburg gait. The person leans their trunk towards the weak side when walking, trying to level the pelvis.
Yeah, you see someone walking and it looks like one hip just kind of dips down with each step. That's often a superior gluteal nerve issue. Very visible sign. Then there's the inferior gluteal nerve, L5, S1, S2. This one supplies the big gun, the gluteus maximus, your main hip extensor. Damage here causes a gluteus maximus gait.
Right. With this one, the trunk actually lurches backward when the heel of the affected side strikes the ground. It's a compensation. They throw their trunk back to prevent themselves from falling forward because the gluteus maximus isn't firing properly to stabilize the hip and trunk during that phase of walking. These gaits, Trendelenburg and gluteus maximus lurch, they're really distinct and powerful clinical clues.
Wow. Okay, that was a serious deep dive into the lower limbs electrical grid. Feels like we covered a lot of ground. From UMN versus LMN, the huge red flag of Cauda Equina, to the specific paths and problems of the femoral, obturator, sciatic, peroneal, tibial, and gluteal nerves.
We really did. And hopefully, Seeing how understanding these paths, these anatomical anchors like the fibular neck or femoral triangle, and connecting them to the specific motor and sensory losses, how that's all indispensable for diagnosis. Remember the CEO versus factory floor for UM and LMN? Remember saddle anesthesia and bladder issues for Cauda Equina? These are the kind of key takeaways that really improve patient outcomes and can even save function or lives.
Absolutely. This isn't just, abstract knowledge for exams. It's the bedrock of good patient care. Being able to see a patient walk, listen to their symptoms, do an exam, and connect those dots to a specific nerve. That's a really powerful skill. So thinking about all this, what does it mean for you, our listeners, as you keep learning?
What raises a really important question to keep chewing on, doesn't it? As you build your clinical skills, how do these principles, the anatomy, the motor sensory maps, the clinical signs we talked about, how do they actually connect with, say, advanced imaging, like that MRI we mentioned for the Cauda Equina case? For each of these nerve injuries, how would you confirm your suspected diagnosis? What investigations would you order? What else is in that diagnostic toolbox?
That is a fantastic thought to leave everyone with. Keep asking those questions, keep digging deeper, keep connecting the anatomy book to the actual patient. Thanks so much for joining us on this deep dive into lower limb nerve injuries. Until next time, stay curious.